Thanks, Dr. Liu Zheng. For wonderful presentation. Thanks for giving us the different ideas in minimal invasive endoscopic spinal diseases. Thanks a lot.
Thank you, Dr. Subhan and all the 5 faculty presenters. Let's welcome Dr. Fu Jishei to host the second part of the lections. Dr. Fu Jishei from Field Hospital of Traditional Chinese Medicine of Southwest Medical University, China. Welcome.
Hello, professors and then colleagues. I'm Dr. Fu from the second hospital affiliated Southwest Medical University. I'm Deputy Director, Minimal Invasive Orthopedics Society, Sichuan Province. It's my great honor to attend this conference. Thanks to the ISUBE, I got this chance for the communication of latest information in the endoscopy spinal field. Let's welcome the first speaker in my section, Dr. Wenli To, University Medical Center 215, Hongban, Vietnam. Vietnam is orthopedic specialty. His topic is UB decompression and vertebral plasty for the osteoporotic vertebral fracture. Welcome.
Hello, colleges. I'm Dr. Nguyễn Toy from Ho Chi Minh City University Medical Center. Today, I would like to present a topic about UB decompression and vertebroplasty for osteoporotic vertebral fracture. As far as we know that the incidence of osteoporotic vertebral fracture is increasing with aging population, and most of the stable OVF should be receive conservation with the high successful, but some of them will be failed. And the reason of the failure consists of the neural compression due to the bone, retrobones on fragment. Second is the progression of the kyphosis due to vertebral collapse. And first one is the intravertebral instability at fracture size. And the fourth one is the foraminal stenosis and nerve injury. So all we agreement that the OVF with neurological diseases should receive surgical intervention. And the surgery must include, first one is the kyphosis deformity correction or post-operative prevention of this deformity and maintenance of the spinal stability and neural element decompression, and especially in the early mobilization. But the elderly patient, they have many things like severe osteoporosis, and they got many comorbidity. So surgery intervention in this patient may be inappropriate because it may increase the hardware failure or increase the incidence of infection, or maybe increase the mortality. So due to the literature, the treatment of OVF should be personalized medicine. There are many research for this treatment, like posterior spinal shortening or paralysis following vertebral collapse, or modified pedicle fraction osteotomy, or some new technique that combine the percutaneous endoscopy, decompression, and vertebroplasty. And especially in our experience, that's the recommendation of Spine Session Observation Society for Orthopedic and Trauma will help us for surgical indication and for surgical approach. But in some case, less is more. I mean that open surgery may be not inappropriate for some patient. So in some patient, we should choose the way like MIS. So today I would like to present a case that's a 72-year-old female patient. She presents to our clinic with severe pain at her right hip, thigh, back for 2 months. And on examination, she had right hip flexion muscle strain, 3, difficulty while walking and sitting. And she got many comorbidity, osteoporosis, Cushing syndrome, hypertension, and diabetes. On MRI, CT scan, and X-ray, review L2 complete bus fracture with the bone or fragment compressed the right L2 nerve root. And according to the AO classification, she had A4. And according to TLIC classification, she had the score of 4. So we explained the surgery intervention for her family. And after the consultation, her family agreement. First one, this is the operating room setting. We perform the procedure under general anesthesia, and the patient lay down on the neutral prone position on radiolution table. We use the arthroscopy monitor and use some standard spinal instrument. The second one is we do a vertebroplasty. We to unipedicular approach for this patient because she has severe osteoporosis and 2 months vertebral collapse. And luckily, after we do vertebroplasty, we recover full height of the vertebrae, and the BMMA distribution is contact to both implant. This distribution will help recover the height, and it increase the stability for a long time. And in case the BMMA distribution not satisfactory, we recommend adding more short segment percutaneous screw fixation like this. The third step, we do UV decompression. Under AP and lateral fluoroscopic guidance, we make a working portal. The working portal is a 7mm transfer incision lateral to the right L2 pedicle, and the endoscopic portal is a 4mm transfer incision caudal to the working portal, and the target point is the point between the transfer process and the isthmus. You can see this is the the skin incision of the vertebroplasty needle, and the yellow arrow is the working portal, and the red arrow is the endoscopic portal. After we make a target point under endoscopic guidance, we identify the transfer process and the isthmus, and we do a partial resection of the transfer process. And then we identify the foramina by cutting more bone at the isthmus and the ligamentum flavum to identify the nerve roots, the partial of the lower part of the L2 pedicle. And then we use osteotomy for resection about 5 millimeters of the lower part of the right L2 pedicle for inside viewer of the fragment. Here we are inside the canal, and you can see the bone here. By cutting the ligamentum flavum at the foraminal, I expose the nerve root. Yes, and are you curious for touching the lower part of the L2 right, the right L2 pedicle, and use the burr for more bone resection? And took the bone part by part, piece by piece. In this surgery, I use a 30-degree scope, and I can easily change the direction of the visualization. And you can see another direction. It's very helpful for us to make nerve safety. Here we are inside the canal, and the bone here. Take on the bone under the root. Inspect more bone. So this bone compresses the nerve root. There are lots of bone in front of the nerve root. This is a free nerve root. And we can confirm the full decompression of the nerve root under fluoroscopic guidance. So after the surgery, the patient could be mobilized with the lumbosacral the next day, and we remove the drain on BOD1. The patient will discharge from the hospital on period 3. The VAS score of back and leg pain improved from 9 to 3. After 1 week later, she can work without assistance. And 3 months post-operation, the VAS score is about 1. We take the CT scan after 3 month operation. We can see here the bone does compress, the nerve will remove. And here, the right L2 pedicle, we reserve conservation about 50% of the pedicle. I think vertebroplasty combined with UV decompression is a safe and effective technique. And the successful formula is personalized medicine, and UV can do the thing that open do. Thank you for your attention.
Thanks, Dr. Wenlik Toll, for the wonderful presentation. If you have some question, please record it and we will discuss it later. Or send the question to the Zoom platform and leave your email. We will contact you. Let's welcome the next speaker, Dr. Takaki Yoshimizu, Sirin Hamamatsu General Hospital, Japan, member of Japanese Society for Spine Surgery and related research, member of Asia Pacific Spine Society. His topic is the learning curve of UBE for lumbar disc herniation. Welcome.
Thank you for Chairman. Can you hear me and see my slide?
Yeah.
Okay. Okay.
Please.
Yeah. I'm Takaki Yoshimizu from Shizuoka in Japan. Today, I'd like to talk about is this slide, this title. This is my today's outline of this presentation. First, I will talk about clinical comparison of UBE versus microscopic spine surgery for lumbar disc herniation. Both UBE and microscopic spine surgery are minimally invasive technique. For many spine surgeons in Japan, micro-rub method is a common procedure to treat lumbar disc herniation. On the other hand, UBE is new technique and not familiar in Japanese spine surgeons. We compared the results of UBE and micro-rub in our institution. The subjects were 147 patients who were treated for single-level lumbar disc herniation, 75 patients who underwent UBE, and 72 patients micro-rub. There was no difference in indication between the two groups. The patient characteristics of each are, as you can see in this slide. Examination items were surgical time, amount of bleeding, skin incision, complications, hospitalization, wound pain at the post-operative 1 day and discharge day. Recovery rate of leg pain and numbness and recurrence rate during post-operative 6 months. The average operation time was 75 minutes in UBE and 66 minutes in micro-rub. It's significantly longer in UBE. The amount of bleeding of UBE averaged 8 grams and micro-rub averaged 18 grams. About complications, 1 dural tear was occurred in each group and 1 hematoma was happened in micro-rub. UBE is performed through 2 of 6 to 8 millimeter incisions, while micro-rub is performed by a 2 centimeter skin incision. There was no significant difference in the length of hospitalization. The wound pain on the next day after surgery was not significantly different, while at discharge tends to be small in UBE. The recovery rate of lower limb pain was 83% in each group, and recovery rate of numbness was 73% in UBE and 78% in microlab. There was no difference in the number of recurrence at 6 months after surgery, with 5 cases in UBE and 6 cases in microlab. Operation time was longer in UBE. Results of LGH herniatomy are almost same in UBE and microlab. Next topic is I will introduce about our learning curve of UBE herniatomy. We researched the operation time of 18 patients who treated by 3 young spine surgeons, including me. 18 patients were consecutive cases from importing UBE. The 80 cases were divided into 4 phases. First 20 cases is inducing phase. Second 20 cases early phase. Third 20 cases middle phase. And last 20 cases late phase. The operation time was 82 minutes in the induction phase, 71 minutes in the early period, 67 minutes in the middle period, and 61 minutes in the late period, with a significant difference between the induction and late period. In about 20 to 30 cases per each doctor, the operative time stabilized at about 1 hour. A review of 30 surgeries I performed was conducted. A surgery was divided into 5 sections, the 5 being portal making, space making, laminectomy, flabectomy, and herniatomy. Endoscopic videos were reviewed to investigate the time needed for each of the tasks of number 1 to number 4. Space making took an average of 7 minutes and 30 seconds for the first 10 cases, 5 minutes for the next 10 cases, and 3 minutes and 50 seconds for the last 10 cases. The time decreased gradually. The first 10 laminectomy took an average of 10 minutes. The next 10 took less than 10 minutes, but the last 10 took 3 minutes and 30 seconds. I experienced dramatic reduction after experiencing 20 cases. The first 10 cases of flabectomy took an average of 13 minutes and 30 seconds, but the next 10 cases took 8 minutes and the last 10 cases took less than 9 minutes. Flabectomy may be the first way to shorten the operative time. The average time for hernia resection did not change with the number of cases. You may need about 30 cases to get used to UBE. Time to make working space got shorter step by step. Time of laminectomy reduced dramatically. Flabectomy is the first way to shorten the operation time. Time for herniatomy wasn't depend on the number of surgery. Finally, I will talk about my NACs for UBE herniatomy. First NAC is about portal making. We have to use image interferer to decide portal location. When we use the fluoroscopy, need to be careful about angle of X-ray beam. Photos are difference between through straight beam and oblique beam. Fluoroscopy change 3-dimensional structures to 2-dimension photo. So an optical illusion always exists. In my opinion, go down vertically to the ground is more safe than using oblique view. In the surgical position, a strong lumbar lordosis narrows the space between the interlaminar space and make the approach more difficult. By placing the hip in flexion and pelvic tilt change to posterior, this flat back is useful position to make interlaminar wide. In my research, as I showed, the time for space making reduced gradually. To reduce time of space making, breathing control is the key. Endoscopic magnifying ratio is 5 to 20 times, so even small amount of breathing interrupts the surgical view as if red curtain were closed. Knowledge of breathing forces is important for smooth hemostasis. There are 3 breathing forces that can become a red curtain in the interlaminar approach. The first is branch of superior articular artery. Second is branch of interarticular artery. Third is branch of inferior articular artery. The trick is to work in areas that do not touch these breathing spots, like here. If you made breathing, move camera to upstream of breathing and detect the breathing point by putting camera closer as you can. Once you detect the breathing point, you never leave camera away from there. If you leave there, you will be sure to lose breathing point in no time by red curtain. You should put the radio frequency device in the closer view. It is the time you need triangle technique. Time of laminectomy reduced dramatically. The key to reduce the time for laminectomy is to check the relationship between the interlaminar space and position of disc preoperatively. Position of disc and interlaminar. These 2 photos are both 3D images of L4-5, but in the left, the disc is hidden in the L4 lamina, while in the right, the disc is hidden in the L5 lamina. This positioning depends on individual anatomy. The amount of osteotomy required depends on how the hernia appears. It is important to compare preoperative MRI, especially coronal images, with 3D CT. The goal of osteotomy is not too much and not too less. In the case of L5S, laminectomy is sometimes not necessary. There are 2 requirements. The disc space must be completely visible from interlaminar space, and the width of interlaminar must be more than 10 mm. If the interlaminar space is more than 10 mm, the camera and tools can through at the same time. Phlebectomy is the first way to shorten the operation time. The first thing we need is to understand the anatomy of ligamentum flavum. Ligamentum flavum is made up of 2 layers, a superficial layer and deep layer. Superficial layer was attached to the dorsal surface of the lower lamina. The superficial layer has a knitted structure that is hard and difficult to handle. And deep layer was attached to the ventral portion of lower lamina. Deep layer is easy to handle with longitudinal fiber structure, so I recommended to remove the superficial layer firstly, like peeling for from caudal side, like this video. Firstly, you remove the superficial layer. You can split deep layer like this. The deep layer also should be resected from the caudal side. We tend to resect the ligamentum flavum from the caudal side because the hernia is often located on the cranial sides. So but this makes it difficult to find the nerve root shoulder. Rejection from the caudal side following the medial border of SAP makes it easier to find the shoulder of nerve root. I recommended this. Time for herniatomy wasn't depend on the number of surgery. Herniatomy is considered to have the greatest impact on surgical outcomes. Therefore, the tasks before herniatomy should be shortened as possible, and more time is spent on herniatomy, I think. This is the last slide. Here is conclusion of my today's presentation. The results of LDH herniatomy are almost same between UBE and microlab. 20 to 30 cases were needed to get used to perform UBE herniatomy. There are some knacks in portal making, space making, laminectomy, and flavectomy. Thank you for listening. Thank you.
Thanks, Dr. Takaki Yoshizuma Mizu, for the wonderful presentation. Let's welcome the next speaker, Dr. Valentin Piontkowski, Lviv Regional Clinical Hospital, Ukraine, Chairman of the Board of the Association of Orthopedics and Trauma Surgeons of the Lviv region. His topic is transforaminal versus interlaminal endoscopic microdyscectomy, pearls and pitfalls. Welcome.
My name is Valentin Piontkowski. I am from Rivne region. It is the western part of Ukraine. And today I would like to say about our experience in monoportal, transforaminal, and interlaminal endoscopic lumbar microdysectomy. What is the factors of the nerve root compression? If you want to understand the monoportal endoscopy and the monoportal microdysectomy, you should understand the factors of the nerve root compressions. One of the most important factor is disc bulge, and you know that it is the most popular factor of the disc compression. And the next one is ligamentum flavum hypertrophy. Ligamentum flavum hypertrophy could be a cause of foraminal stenosis and central stenosis also. The next one is a facet joint hypertrophy. The facet joint hypertrophy could be a cause of foraminal stenosis and also compression of nerve root, exciting nerve root, and traversing nerve root. In this picture, you can see a compression of traversing nerve root between the disc bulge and the lamina. In this picture, you can see the complete disc resorption caused by the Kyiv spinous. And here you can see a sclerotic spondylolymphitis, which is a factor of nerve root compression. The pain in the low back could be could have a 2 point. One point, it is an inflammatory pain, is caused by the release of the chemicals in the nucleus that irritate nerve endings in the annulus fibrosus. Another one is a mechanical pain, is due to the physical compression of the nerve roots as a result of the herniation or another factors of nerve root compression. Just a moment. What about the endoscopic monoportal approaches? There are three most popular endoscopic monoportal approaches: lateral transforaminal, posterior lateral transforaminal, and interlaminal approach. We prefer to use a posterior lateral approach because this approach can show you how easy to perform the facet joint resection, and you can also revise the disc space. If you use a lateral approach, performing the disc space revise, it is not so easy because the trajectory, your trajectory is direct into the spinal canal, not to the disc space. Why is possible? It's possible because everybody know a Cambion triangle. Cambion triangle, it is a triangle between exciting nerve root and the lower part of pedicule of lower vertebra and the superior part of superior facet joint, SAP. We use a two technique, outside in and inside out. As for me, inside out is not so easy technique because you cannot see nerve structure. Outside in is more better technique because you can see the nerve structure, you can see the nerve root, and you can see the disc bulge. And under the visual control, you can perform the microdystemia. Also, posterior lateral transforaminal approach is better because you can perform the partial facetectomy in cases of foraminal stenosis. And you can perform the disc space revision, and it is possible on L5S1. If you use only posterior, only lateral transforaminal approach, it is mostly impossible on L5S1 level. Of course, posterior lateral transforaminal approach better because you can revise the exciting nerve root and you can revise the traversing nerve root. You can revise the epidural space. You can perform the partial superior facetectomy, and in case of foraminal stenosis, you can perform the widening of foramina. Excuse me, it is a small disconnection. Sorry, it is a technical problems. Okay. Okay, so transforaminal approach, how I do it. First of all is preoperative planning. You should understand if you perform the transforaminal approach on the level of L5S1, it is most important pelvic X-ray, and you must understand, is it possible or no? Because if you have a high iliac crest, it could be impossible. So it is the first step in preoperative planning. Another picture show how we find the entry point. If it is a L3, L4 level, we use the distance from the midline around the 8-10 centimeters. If we want to perform the microdysectomy on level L4, L5, it is around 10-12 centimeters, and the 5S1 around the 12-14 centimeters. Measurement, skin landmarks, and after that we use local anesthesia with intravenous sedation. After that, we perform the punction of SAP, and the other X-ray control you must see in the AP view and lateral view that the tip of your needle stay directly on the tip of the SAP. And where you should put the tip of endoscope, it is really difficult question, but very easy answer. It depends on type of disc herniation. If it is a central disc herniation, the tip of your endoscope should be stay directly on the midline. If it is a paramedian disc herniation, the tip of your endoscope should stay around the medial pedicular line. And if it is a foraminal or extraforaminal disc herniation, the tip of your endoscope should stay in a lateral pedicular line, or a little bit out of lateral pedicular line. Of course, the key wire placement depends on the type of disc hernia. The next one is inserting of the key wire, and after that, small video will show you how I do it. I stay the key wire in the spinal canal and then perform the small skin incision. And after that, I will perform the soft tissue predilatation. One smallest dilator, another one a little bit bigger. X-ray control, and your dilators should be directly on the tip of the SAP. And the biggest one, soft tissue dilator. You must understand that the most painful structure, it is a skin and fascia thoracolumbalis. Another soft tissue, not so painful. So when you perform the local anesthesia, you should do it very, very good in a skin and in a fascia thoracolumbalis. Another step, it is a placement of a Tom Sheedy needle with a sharp tip. And using a hammer, you do the small hole in a SAP. X-ray control. And you change the Tom Sheedy trocar with a blown tip and go to the spinal canal, directly to the midline. Okay. And in an X-ray, the tip of a Tom Sheedy needle should be in a lateral view near the posterior longitudinal ligament, on the AP view near the midline. The next step is drilling. We use few drills, bone drills for facet joint drilling. It is 4 millimeters drilling, the first one. And during this procedure, we should ask the patient if he or she feel any pain in the leg. It is most important step, because if a patient feel any pain in the leg, it is mean that we could touch the nerve root. So the patient must be under local anesthesia. And after this smallest drill, we use another drill, 5 millimeter with 5 millimeter diameter. And the next one will be 6, 7, and 8 millimeter drills. And X-ray control should show us that our tip of our bone drill stay directly on the posterior longitudinal ligament in lateral view and near the midline on an AP view. And the next step, it is insertions work in cannula and insertion the endoscope. If you perform the correct approach, it is very easy to see the disc herniation just after the approach. The small pieces of disc material go to the working cannula, and you should remove it piece by piece. On start a little bit slowly, because it is very dangerous to catch this piece of this material because you can damage the nerve structure. But after a few minutes, when you removed all the pieces, small pieces, you can see the nerve root, and you can continue remove this material more fastly. And during the procedure, we use a radio frequency trigger flex electrode. It is very important tool, because during procedure you can see the bleeding, and small pieces of this material and small pieces of ligamentum flavum you should remove using this electrode. The temperature on the tip of this electrode is around 42 degrees, so it is not dangerous to use this electrode near the nerve root. But if you touch the nerve root, you can damage it. So around the 1 or 2 millimeter near the nerve root, you can use this electrode without any problem. If you catch a little bit bigger piece of this material, it is impossible to remove it through the working channel. You should remove it together with camera. In this small video, a little bit bigger piece of this material. And this video show us also a big piece of this material. It is something like a fishing very funny. It's a little bit bigger, around the 2 centimeters. Disc sequester. Another one. And this is very hard and very big disc sequester. So together with camera and with working cannula. Another one, big disc sequester. And also big sequester with hard soft tissue. I think it is a piece of annulus fibrosus. The biggest one, it is around 8 centimeters. It was a patient with a Cauda syndrome, but all sequester we removed. The last step, it is an endoscopic inspection of the decompressed nerve root. We should see the free epidural space, free nerve root, and we should see the pulsing of the nerve structure. It is an MRI before the surgery and 2 days after the surgery. This is MRI with migrated disc sequester. It is a caudal migration before and after surgery. There is a cranial migration before and after surgery. There is a central migration before and after surgery. There is a central disc herniation. It is not easy to remove all this material through the transforaminal approach. So if it is a young patient, we prefer to use a posterior interlaminar approach, because through the transforaminal, it is a little bit difficult to perform this microdysectomy, but we did it through the transforaminal approach. Far migrated disc herniation can be extracted by the transforaminal approach also. It is a surgical entrance for far migrated herniation and extraction of migrated disc herniation under the fluoroscopic control. It is an MRI before and after surgery. Most important point, it is foraminal stenosis. In this picture, I would like to show you a mechanism of foraminal stenosis due to a facet joint hypertrophy. So as you see, the superior tip of facet joint could be caused of exciting nerve root compression. So the treatment is a partial facetectomy. MRI diagnostic, everybody knows that on MRI we can see the foramen and nerve root, and if it is a foraminal stenosis, it is too easy to see on MRI. It is a picture during the foraminotomy, and you can see on a 12 and 11 level the part of facet joint after the facetectomy. This picture shows us the endoscopic picture, CT picture after the partial facetectomy. And on the right, you can see the Lee classification of the foraminal stenosis. And I would like to say that very easy to perform the foraminotomy if you have a foraminal stenosis in a 2 and 3rd zone. If you have a foraminal stenosis in the 1st zone, according to Lee classification, better to perform interlaminar approach, because it is too difficult to perform the foraminotomy in the first zone. So, interlaminal endoscopic microdysectomy. It is very interesting, but this method also has perils and pitfalls. Interlaminal, we use instruments of valve production for interlaminal approach. Indication. I think that most popular indication it is a L5-S1 level disc herniation, and if patients have a wide interlaminar space, it is very easy and very fast to perform the L5-S1 disc herniation. In our hospital, we perform L5-S1 microdysectomy maybe during the 12 or 15 minutes. Because it is very easy and very fast. If patients have a high iliac crest, it is also difficult and impossible to perform the transforaminal approach. You can perform the interlaminar approach. And if patients have a cranial migration of disc herniation, it is also better to perform the interlaminar approach. How I do it? The first step, it is landmarks and inserting the working cannula. It is around 1 or 2 minutes. After that, you go to the ligamentum flavum, perform the small hole around the 4 or 5 millimeters to the epidural space, and when you start to see the epidural fat, you push your working cannula and turn it, and after that you have the picture like under the microscope, and you remove the disc herniation. This is a clinical example. Another one. And one more. Another one. This is this material. So, transforaminal versus interlaminar. We use a transforaminal approach for microdysectomy, endoscopic microdysectomy in cases of medial, paramedial, foraminal, and extraforaminal disc herniation. But if it is a young person and if it is a medial disc herniation, we recommend to perform the interlaminar approach. If patient need partial facetectomy, it is very easy performed through the transforaminal approach. Sometimes impossible to perform the transforaminal approach on the L5-S1 level because of high iliac crest. Far caudal migration of disc herniation, in these cases, better use the transforaminal approach. And it is very good method for foraminal stenosis in a 2 and 3rd zone according to the Lee classification. Interlaminar approach we prepare if it is a medial and paramedial disc herniation. It is very nice, direct, easy access to the disc material and very fast. You don't need to perform more and more X-rays like in a transforaminal approach. You need only 2 or 3 X-ray picture, and you do this approach very fast. and it is really nice method in cases of cranial migration of disc herniation. I would like to say thank you, my first teacher in the field of endoscopy. It is Mariusz Miguel from Katowice city, from Poland. And I would like to say thank you, Jaap Hoogland from Germany, Munich. He is a CEO of Maxmo Spine Products. It is a picture from the Ukraine. It is a duck hunting. Our Ukrainian people very kindly, and I would like to invite everybody of you to Ukraine. Maybe you would like to try the hunting, duck hunting. Welcome. Thank you very much for your attention and have a nice day.
Thanks, Dr. Valentin Piontkowski. Let's welcome the next speaker, Dr. Mohosen Said, Odessa National Medical University, Ukraine, head of endoscopic and neurospine surgery and minimal invasive surgery in South region of Ukraine. His topic is specific transformational endoscopic discectomy lumbar spine. Welcome.
Thank you, my friend, dear my colleagues. Our topic today, features of treatment of hernia discus without using monoportal endoscopy and ultrasound nucleoplasty. According International Health Organization, the pain back is the most problem in disease and degenerative problem spine at all. Spinal osteochondrosis and spinal pain, which leads to stability, also very big problem, about 14% of people of working age. In more than 15% cases, the degenerative problem affects in lumbar spine 35 and cervical spine about 13 and thoracic. The most serious from complication of lumbar osteochondrosis is hernia interbody disease, which future leads of the development of stenosis. Stenosis of lumbar spine usually has severe patients, compression of the nerve roots and complication with hypertrophy and yellow paramedial ligament and another anatomic structure, often nucleus pulposus. Is degenerative problem also leading to stenosis? The wide problem and we do compression of the foraminal nerve and vestibularity. Reducatal the netrovascular size and or height of the articular processes. The class is old standard, usually using opening microdyscectomy. However, such operation is not the best because how ranges of contraindication, long term of rehabilitation, few weeks needing to full rehabilitation. Hypericanius of insterfity treatment sold according to the McNabb rating scale to 16%. Coronately various modern and very progressive method, malo-invasive biportal and monoportal endoscopy methods of widely using now on many countries of the world. To increase our purpose, to increase the efficiency of surgical treatment intervertebral herniation disc of various localization by the method of monoportal transfemoral endoscopy, discectomy, and ultrasound nucleoplastic deviably, and algorithm for choosing the optimal treatment method of maloinvasive surgery. Method and material and methods. A retrospective analysis of treatment result 1 year was carried about 188 patients with degenerative osteochondrosis of the spine and hernia of the lumbar spine of various cations. 74 patients, 55 women and 44 and 6 men. We deleted for two categories. And independent monoportal endoscopy under local anesthesia. 140 patients underwent ultrasound nucleoplasty. All patients before and after operation underwent mechanic series of diagnosis: MRI, radiography, ultrasound, electroneuromiography, Doppler vascular, and biological McNaba show the result until and before. The patients were distributed according to the level of spine. As you see, L3, L4, it's lumbar spine, about 30 patients, and L4, L5, more, 66, and L5 is one, about 82. Nucleoplasty was performed percutaneously without incision. And during of surgery, about 25 minutes, very short time to meeting the type of operation. And ultrasonic apparatus was used at low frequencies with the possibility of increasing the frequency if necessary or needing through aspiration. It's no problem. Puncture needle diameter, we always using about 15 G. Compression of the radical canal on a lateral and extraforaminal compression, as you see, or compression of central and radical canals, 1 and 2 step in stenosis. Account and chronic radical syndrome. Contraction to general anesthesia. What we showing two subjects. The first about interlaminar endoscopy, and the second about ultrasound nucleoplasty. What's the difference and indication for any method? As you see, it's very big compression and using local anesthesia. Continuous. Indication for every method. For ultrasound, indication for ultrasound, nucleoplasty,
Yeah.
effective of conservative therapy.
Yes, yes, and that's because there are no question for this section for speakers, so we will finish this section. Is that you Dr. Said, you used
Давай следующий. И давай нуклеопластика покажем сразу следующий видео. Через слайд будет следующий видео. The next video is about nucleoplasty. Local anesthesia function, as you see, about 20 minutes all time operation from beginning until the end. No pain here inside disc, needle, and will be finished. It's ultrasound nucleoplasty. In the end operation, no pain syndrome at all. No, we show it all criteria for indication. Result, as you see, agreed about 118 patients and will about 46 and satisfactory about 20 and unsatisfactory 4 patients. So result of electroneuromyography, as you see, very good, about 156 and middle about 20 patients and middle progressive about 5 patients. Ultrasound, vascular ultrasound for all patients was negative. Good tonus of vascular, 140 patients and middle about 27 patients and weak vascular tone about 30 patients. Conclusions. For thoracic stenosis, for hernic stenosis, biportal endoscopy UB is the best treatment, is the best method at all. Biportal also endoscopy indication for central stenosis, stenosis of the spine canal. Also UP is a better method. It's our analysis. For compression of the radical canal, unilateral and extraforaminal compression, the better method in our research is monoportal transforaminal type of endoscopy. For median and intraforaminal disc herniation, the most effective treatment it's ultrasound nucleoplasty. Ultrasound nucleoplasty is the most effective and very on complex regression of pain syndrome is noted already the operating taker. About 2 hours, patient can't to lift hospital. No AG, it's very important. No AG restriction in performing ultrasound nucleoplasty and practically or restriction of the somatic state and low recurrence rate of hernia. No blood loss at all, no blood lost through aberration and low Taizhou pressure. Thank you for your attention, my friend. Thank you.
Because there are no questions for speakers, so we will finish this section. Thank you.
Thank you, Dr. Fouché, all for surgeon presentation and all questions from audience. We will have a break time and rest and back to conference almost in 1 hour in 1 p.m. Ukrainian time. So in 50 minutes, we are waiting you here. See you very soon.